Good afternoon, everyone. Just after 1 o'clock, so we're going to get started. This is Nancy Kelly from the New England QIN-QIO. Thank you for joining us for today's Interact webinar series conclusion. Here with us today, we have Carol Dietz, Sheila Eckenrode, and Florence Johnson. Before we get started, I want to go over a few housekeeping items. First, this call will be recorded for training purposes. I'll provide you with details on accessing the recording at the end of this webinar. The lines will be on mute for the duration of the presentation. However, we will take questions at the end, and we'll provide you instructions on how to unmute your line. Just to note, too, we've been having some phone challenges lately. I'm not sure if it's due to the weather or something else with our phone carrier system, but just wanted you to be aware of this. If the line happens to drop on your end, please hang up and dial back in again. We're crossing our fingers this doesn't happen today on this call, but please know that we are looking into this and are probably going to be using new numbers in the future. So at this point, I'm going to pass the call over, or the webinar over to Carol to begin.
Good afternoon, everyone. Welcome, welcome, welcome to the last session of this very important work of the Interact Quality Improvement Program webinar series. Can't believe it's been 8 months since we started this wonderful, wonderful journey. I do want to let you know I'm one of the quality improvement consultants here from the New England QIN-QIO, and I'll be the moderator for this session. But I am also here, as Nancy has mentioned, with Sheila Eckenrode and Florence Johnson. Before we begin, I want to just talk about one other issue that we've also noticed. Please don't put us on hold. We're begging you. You know, every facility has lovely music, but that we don't want to hear it. So please do not put us on hold. And everyone right now is on mute, and Sheila will be requesting some of our colleagues to get themselves off of mute. So please, if you hear your name, it's going to be *6 to get yourself off of mute, but Sheila will go through that once she does a shout out to some of our nursing home colleagues. As I always start off our session, these are our partners in the New England QIN-QIO, and this is important for each of you from the different states. We're hoping that your nursing home is part of a care transitions community within your state, but if you're not, if you're interested in joining, or if you have a question about what a care transition community is all about, these are your go-to people. So in Connecticut, it's Florence, Sheila, or myself, as well as Ann Elwell. She is our leader of the care transitions team here in Connecticut. In Rhode Island, it's Kathy Calandra, Amelia Odom. In New Hampshire, Joyce Johnson, Margaret Crowley, and Tim Boyd. In Vermont, it's Liz and Gail Harbour. Massachusetts is Lynn Chase, Cheryl Leary, and Lori Nearbaum. And in Maine, it's Maureen Leary and Danielle Hersey. So please know that they are a phone call away. If you have a question, concern, whether it's about Interact or just about the care transitions community in general, this is the work that we're doing, and it's very important work that we're doing. It's all about patient care and resident care. I started off 8 months ago talking about the New England QIN-QIO. Again, this is just a refresher slide that we are one of 14 QIN-QIOs. QIN stands for the Quality Innovative Network Quality Improvement Organizations. We want to become the healthiest region in the United States. That is our goal. And another goal we have is to reduce 30-day unplanned hospital readmissions by 20% by 2019. And you are going to help us get there by implementing the Interact Quality Improvement Program in your nursing home. So today's session, the objectives for today, Florence is going to talk about the journey that we have started and how it is ever going to continue on. We're going to discuss what an Interact nursing home should look like. It's not about just the tools. And also we're going to have some, as I mentioned, some nursing home colleagues join us in the discussion of lessons learned as they have gone on their journey of implementing Interact into their nursing homes and wanted to share their best practices with you. Because it's all about sharing. It really is all about lessons learned so you don't have to make the same mistakes or hit the same barriers that they've hit. And finally, the last 15 minutes, we're going to have that state-specific session. Connecticut nursing homes will stay on the line, and the New Hampshire folks will have that phone number that you'll jump off the line and jump back on with a phone number to talk to Joyce and Tim for your last session together. What a great way to end our day, our sessions together, by congratulating each and every one of you who have made it a point to make it to these webinars on a monthly basis, that you've worked with your team. You've done your homework, and it's not about the actual homework, but it's about putting the processes in place, making sure the education has gone out to the right staff, to all the staff with some of the tools, and then monitoring the implementation of each of the tools to make sure that it's being used correctly at the right time for the right patient. So congratulations to all the hard work, and I can't tell you how excited we are here at Qualidigm, at the New England QIN-QIO, to know that you have taken this journey with us. As we always do, we have a polling question. Just to let you know, this is very important to us. We want to know about you using your readmission data. So in order to use your data, you have to submit your data. So the polling question, if you can just take a few minutes and answer this question for us. My facility has started inputting data into the 1, Advancing Excellence Safely Reducing Hospitalization Tracking Tool. Number 2, Interact Readmission Tracking Tool by using a computer. Or 3, you're using the Interact Readmission Tracking Tool but using a paper tool. 4, our facility is using another readmission tracking tool. Or 5, our facility has not started tracking readmission data yet. So please, it's just going to take a few minutes. And you need to make sure you hit the submit button on the lower right-hand corner of the screen so we can see your data. So thank you, Florence, for making sure I say that. And the remaining time, there we go. Okay, so thank you so much. So we have 10 out of 40 using the Advancing Excellence, 10 out of 49 using the Readmission Computer Tool, 3 out of 49 using the readmission paper tool, 2 out of 49 using another type of tool, and no facility has said we haven't started tracking readmission yet. You have just made my day. Thank you so much. Now, yes, we had 23 that have not answered, so please think about, again, without the data, you don't know what direction to work into. So thank you, thank you, thank you. And we're going to click out of here. All right, Florence, I'm going to turn this over to you to talk about the journey that has been started, but it's not over yet.
Thank you, Carol. As Carol said, when we started this about 8 months ago, we talked about this being a journey, and it is a journey that the destination is still far, far in front of us. I told you in the beginning that it could take up to a full year to fully implement the Interact program. And the goal has always been not to look at Interact as individual tools, but to look at it as a complete program. And I talked to you back then about baking a cookie and the importance of having every element of that recipe in that bowl to actually make the kind of cookie that you're making. Over the past 8 months, we've introduced you to every single tool within the program and have tried to walk you through how to implement each tool. I am a realist, and I'm realistic, and I know that not everyone I don't even think any one particular facility has been able to implement all of the tools. It takes a lot of work, takes a lot of dedication to implement correctly, and to have full buy-in from all your staff. I understand some of the challenges that we're facing with staff instability and lack of buy-in in some areas, but I plead with you that you continue to make this a priority and that it becomes a way of life in your facility. It becomes a culture instead of something that we look at as another something that we're doing. This is not a fly-by-night idea that is going to go away. If you are looking to be a part of an ACO or preferred provider network, you will have to change how you currently do business. All ACOs and all preferred providers are wanting people to implement Interact. And that goes beyond just looking at your 30-day readmission using those tools. That goes into looking at the way you provide care, improving quality, and as a result of that, your readmission rates will come down if you do the right things for the right reasons. So I encourage you to continue your slow implementation. Avoid all those pit holes along the way. Do not look for any stop signs. Do not stop to collect your $200. I need you to just keep going, and we are here to support you. And I am proud of what you guys have been able to accomplish in such a short period of time, but it's not over. We need to continue the work. Thank you. To you, Sheila.
Thank you, Florence. Good afternoon. It's Sheila Eckenrode. I'm going to talk a little bit about what an Interact nursing home should look like and review some of the past lessons we've had together. So as Florence said, it's not just about the tools. It's not about forms and pieces of paper. It's about changing the way we behave, changing the way we process information. So if you remember way back, we talked about the first step being to develop an Interact team, and that team needed to be multidisciplinary. Many facilities talked about using an existing team because they were loath to add another meeting to an already burdened schedule. So if you have a QI team, or if you have any team that gets together to look at data, whether it be pressure ulcers or antipsychotic use, that you could roll looking at readmission data into that curriculum. Line staff is essential. We can't move forward without them. A team implementing Interact needs representation from CNAs. At the very least, maybe even dietary, housekeeping, recreation. It needs to meet at least monthly. The data needs to be reviewed monthly. Back then we talked about team norms, taking a few minutes to, as a group, talk about how you're going to conduct yourself as a team, whether you're going to have an agenda, how long you're going to look at data, how people speak, does everyone speak in turn, who's in charge, who's going to take minutes, that type of thing, and of course reviewing the data and reporting out. Now, I was mentioning to my colleagues yesterday that although I've enjoyed very much doing these webinars, I've grown sort of weary of the sound of my own voice, so I can't imagine how weary you all must be of it as well. So I've invited some long-term care colleagues to jump in, and they were kind enough to agree to do that. And so that's Tina from Kimberly Hall North and Laura from Glastonbury. So I will invite you to speak throughout this short presentation, Tina and Laura, and in order to do so, because I know you're muted, you're going to need to press *6. So I'm wondering, Laura, if you could go ahead and press *6 and share a little bit about which team you used to facilitate Interact implementation.
The first thing we did is actually called up at Solidigm and asked for some advice because it seems like a really very large undertaking. And the recommendation was to start slow in a controlled, maybe one unit, so that we could see where we failed and what worked and what didn't work. And then once we did the trial over a week or two, we could then introduce it to the rest of the staff and the other nursing units. So we started first with just the stop and watch and found that everybody bought into it, except we didn't know where to keep the little pads, so we ended up buying little plastic sleeves and kept them all over the nursing unit where anybody, including family member in rehab, could just stop and pick up a stop and watch. And once we got that going, it just kind of fell into place. So that was basically the first stop for us. And then we introduced the S-bar. And then once we got to the S-bar and the stop and watch, we went on ahead to do our red envelope.
Thank you, Laura, and I know you've done a great job with this there at Glastonbury, and I'm hoping that you'll soon see the results of the implementation of these processes in lower readmission rates. Thanks for sharing.
Thank you.
Okay, we talked about the second step way back in the winter. We talked about collecting data at the facility level. We can produce reports here at Paladine. We can produce facility reports, but there's quite a long lag time between the time that the data is gathered and the report is received because we get them from CMS. So the whole idea of collecting data at the facility level is that you can be nimble. You can react to trends in a timely fashion. So we had talked about using the Interact hospitalization rate tracking tool, or a paper tool, or a corporate tool. Any way you can collect data on a monthly basis and then use your team meeting to feed that information back. So hopefully people are either doing that or thinking about ways to get that done. If you recall, in the tools that we had presented, there were some required fields, and it's not a whole lot, and I've gotten feedback from facilities that if you sort of keep up with it and do it on a daily basis, it's probably about 5 minutes. So you're including the resident's name, the date of discharge, the status on admission, were they Part A or Part B or straight Medicaid, and then looking at the folks you send out and why, and the outcome of the transfer, were they evaluated in the emergency department or were they actually admitted. This is a function that really needs to be assigned to a discipline. So either billing does this daily or admissions does it daily. If you assign it to one person, invariably that person will leave and it will go away. So when you think about gathering data and entering it daily, think about a function that's similar that you could attach it to so it will live on regardless of someone's vacation or a staff change. Okay. Carol, speaking of data, Carol's going to tell you a little bit about what statewide data we've collected and how we're looking in terms of readmissions.
Hi, everyone, again. This is Carol. We started off, I know, Sheila just introduced me, but you never know. Sometimes I change my name. We started off 8 months ago looking at some CMS readmission data from nursing homes per state. And I wanted to end our sessions together looking at the same data but with updated data. Now remember, this is CMS data, so there is a lag time. So we have 8 quarters worth of data with our most current data that we'll be looking at is first quarter 2015. So that's January, February, March 2015. And this is the earliest data the most current data that we could get. So we're going to start off with Connecticut. So as you're looking at this report, this is the percent of statewide discharges to skilled nursing facilities that were readmitted within 30 days of their admission. So the first thing that you're looking at is the 4 quarters worth of data. It starts at second quarter 2013 all the way to first quarter 2015. If you notice, in the green line, that's the New England region aggregate data. So that's the percentage of all 6 states aggregated together, and the rate is around, I want to say like 19%. For Connecticut, we're hovering around 19%. A couple of the quarters were up in the 20 percentile. But just looking at this data tells us we haven't had too much movement. And we know that every hospital in the state's working on readmissions. Everyone on this call in Connecticut is working on readmissions, but we just haven't gotten that magic bullet to decrease our readmission rates within the nursing home setting. So one good thing is we had not started this initiative, this Interact initiative, until second quarter 2015. So that we started in February, but February and March was just sort of the introduction to what is Interact, what is data. So we really didn't start looking at our data until second quarter 2015. So it's going to be very interesting to, once we get the new data back from CMS, which will be second quarter 2015, to see if we start seeing a drop in our readmission rate. So that's Connecticut. So we're hovering around that 19% for the past 2 years. So this is Rhode Island, very similar to Connecticut. So again, same eight quarters worth of data. It's discharges to skilled nursing facilities that were readmitted within 30 days. And again, they're hovering around 19%. That green line is the New England aggregate data. Again, it's around 19% too. So Connecticut and Rhode Island, very similar. Then we look at New Hampshire. This is the New Hampshire data. Same 8 quarters worth of data. Same measure of nursing homes that discharges to nursing homes that were readmitted within 30 days. You are hovering around 16.5% readmission rate, which is outstanding. But again, as you look at this data, which is below the New England rate, so yay for New Hampshire, but as you look at it, there's no decreasing, no consistent decreasing of the data, of the readmission rate, and that's what we're looking for. Now we look for Vermont. We look at Vermont's data, again, 8 quarters worth of data, way below the New England average. You are hovering around 15%. That's wonderful, but again, we're not seeing that consistent downward trend. And that's why we have implemented the Interact program into the nursing homes, because we want to see a consistent downward trend of data. And now we're looking at Massachusetts, so that is very similar to Connecticut and Rhode Island. You're hovering around 19%. Your readmission rate is around 19%. Very similar, as I said, to the New England region aggregate. And then finally there's Maine. You're hovering, your state nursing home readmission rate is around 17%. So it's a little higher than Vermont and New Hampshire, but well below the New England aggregate readmission data. But again, you were starting to see a nice decrease in that first, second, and third quarter of 2014, but now you're sort of creeping up with the fourth quarter 2014 and first quarter 2015. So it's really important to look at the data, know where you're going, know where you've been, but also have a good, clear path of where you want to go and how you're going to get there. And the Interact program being implemented in nursing homes is one way to get to that point of a consistent downward trend of readmission. So I'm turning the program back to Sheila.
Thank you, Carol. I'm going to talk again about where we've been and what we've presented in the past, and just sort of give a broad overview, and again invite Tina and Laura to comment on what it was like to implement these tools in real time. So if you recall, we talked about implementing the quality improvement and medication reconciliation tools. The quality improvement tool is the tool that you use to review an individual unplanned readmission, and this is a really powerful thing. And if you're not doing this within a team meeting, I very much encourage you to do it. If you don't feel that you have time to integrate this into a quality improvement team meeting or an Interact implementation team meeting, then try to do it on the unit with the people who are involved. The idea of using the QI tool is to look at an unplanned transfer to assess how things went and whether or not things could have been better. If things could have been done differently, if multiple systems were involved, you might consider taking the case or the root cause analysis itself, the QI tool, to your community meeting and reviewing it in the community meeting. I know some communities make that part of their agenda, but that could be a powerful thing. It could be a very powerful way for different providers to see an individual readmission from a different perspective, if you will. Of course, with anything like this, the goal is inquiry and learning and not blaming. That's always difficult to communicate, but we won't get very far if people are frightened to talk about what they saw and what they think could have been done differently. Medication reconciliation, we reviewed that tool as well, and that is something that most of, I think, facilities have some sort of process in place to do, but that's very important. You know, if it's your resident, what kind of medications they went out on, when they come back, if there's some sort of glaring omission of something they took in the home that was discontinued in the hospital, or conversely, something that was added in the hospital that seems a bit off. It's important that someone sits down with that chart, looks at what was added, and looks at what was discontinued, has a discussion with the provider about that. We talked about communication tools, and this is where the rubber meets the road in a lot of ways when it comes to transfers back and forth from acute care and long-term care. The Stop and Watch tool, Laura talked a little bit about that. And again, we know that's usually very well received because it becomes a template for people to communicate concerns that might be early and vague, and they might not feel comfortable communicating without that prompt. So when somebody's a little bit off, they usually eat 2 puddings for dessert, and now they're only eating 1, and it seems like a silly thing to report up to a nurse, but these are important. We know from research that these subtle changes in resident conditions very often harbor problems down the road, and I think any experienced clinician would agree with that. We talked about SBAR as an industry standard in communication between providers and between levels of care. And again, this isn't about the forms, as Florence mentioned. This is about structuring our communication so it's clear and it's effective. Nursing home transfer forms has been a big project to implement, but I know that there's been some incredible successes. I didn't think personally I'd live to see the day that when a W-10 wasn't attached to a resident leaving for the emergency department, but it seems to be happening, and that's great. And I'm going to ask Tina to talk a little bit about that. Tina from Kimberly Home North, can you tell us a little bit about what it was like to implement the nursing home transfer form? Any bumps in the road? You're going to have to press star 6 to unmute yourself.
Sure. When we rolled it out, we talked about it. We did a lot of education. There was a lot of confusion because, as you just said, the thought of not having a W-10, I had a couple of times where they were doing both. So what I did was I, went over it with the supervisors, who went over it with the charge nurses, and it was a printed copy so that they could familiarize themselves with what information was on the form prior to it being an emergency. My feeling in the nursing home anyway is that it's this very stressful time when you're sending anyone to the hospital, and I didn't want added stress where it was completely unfamiliar. So they knew the type of information that would be on the form prior to an emergent event. And then I made a bullet point of all the things that you have to do when you're sending someone to the hospital, and I put it on the front of a binder. And inside that binder are all of the papers that could possibly be affiliated with a hospital transfer. If they're a DNR, you need that form. Silly forms that aren't silly, but a bed hold, because sometimes people get anxious looking for things, so we did that. And then we talked about each time, I would review the paperwork and see what they missed or what they could have done better, and then we would talk individually about how we could have made it smoother. And they really bought in after they called report to a hospital a half an hour after the transfer, and the hospital said, you gave us really good information, we're very happy with this. And then that sort of went around the building, and they were like, oh, a compliment, somebody actually liked it, and we talked about why we were doing it and how this information made it better care for the residents. So it became less cumbersome and more of a better productivity. Now it's even on PCC, it's a job done, it's something they're familiar with, and they're much happier. So I don't know if that helps.
Thank you, Tina. I think that helps a lot. And I'll be calling you to ask you a little bit more about PCC, because I know a couple of facilities that would like to use that to organize their transfer information. Oh, point-click care. Florence doesn't want us to use acronyms. So, yes, you bring up a good point, Tina. It's so good to get that good feedback, and I think that we're getting that here at Qualidime. I'm hearing from EMS personnel, I'm hearing from emergency department personnel that these processes and these documentation tools are really helping them do their job. So I want to make sure that that information gets back to you folks as well. And, of course, with the red envelope, the capabilities list is included either on the outside or the inside, and that's letting the emergency department know what kind of things you can do to treat someone acutely within your facility, and the acute care transfer list on the outside of the red envelope. So there's the red envelope. Yes, the red envelope is only in Connecticut. So if you want to use it in any other state, we'd be happy to help you do it. So again, we know it's going to contain the Interact communication tools, the current medication list, base sheet, advanced directives, and it will be sealed and opened by the emergency department staff. So we've spent a lot of time and creativity and energy among long-term care facilities in the state of Connecticut in implementing this process, and kudos to all of you. Remember the Interact decision support tools. They can be very, very helpful to you, especially with new personnel. Helps people know what to do next when there's an acute change in resident condition. Standardizes the type of care and response. So noodle around in those, if you will. And of course, Interact has advanced care planning tools, and we know that for the most part, I think long-term care facilities do a good job with advanced care planning. But I would encourage you to, again, show your staff the advanced care planning tools and Interact with the scripted guide for facilitating a discussion that can be uncomfortable, many people find useful, and it also sort of prompts you to make the process of discussing end-of-life care iterative, so it's happening every few months. It's happening anytime there's a change in resident conditions. It should happen, that discussion should happen between the resident staff and the resident's family every time there's a hospitalization, because chances are good that's a result of some change in that patient's status. And again, when to recommend palliative care, hospice care, or both of them. All right, so that's kind of where we've been. I'm going to turn this back to Carol. Again, thank you, Tina and Laura, for telling us tales from the field, and congratulations to both of you.
Hi, this is Carol again, and I just have a couple more tools that I want to talk about that we haven't really addressed because of the time element for each of our sessions. So the first one is the Interact implementation checklist. And I don't know why we don't have a picture of the Interact tool here, so the implementation checklist, so I apologize. But this is on the Interact website. If you go into the tools, the 4.0 tools, and down in the very top part of the tools listing, you will see this implementation checklist. And it's very important that your team complete this on a semi-annual basis. It helps you to assess the degree to which the entire Interact program is being implemented, as well as it reveals opportunities for further implementation. I can't stress this enough, that this is looked at as a team, not just, oh yeah, I think we do it, yeah, I think we do it. You need to really assess when did you implement it, how are you monitoring it, the success of each of the tools, and the good, the bad, and the ugly for each of the tools, and the processes that you've put in place so you can sustain the work that you're doing. Another tool that's available on the Interact website is the implementation guide, which is going to be used by your Interact champions and the trained educators, and it provides an overview of the program and the tools, as well as strategies for implementation and sustaining the program over time. It's a very important document that you have in your toolkit, and that as you are implementing or strategizing on how to implement a new tool, that you haven't implemented before, you use this guide to make sure that all the different areas are addressed. And another tool that's available is the Quality Improvement Summary Worksheet. And this is used to summarize the findings that are documented in each of the QI tools that are being used to do your root cause analysis for your unplanned readmissions. And it helps determine if there are any common factors involved in your hospital transfers. Are these transfers occurring on certain days of the week, a certain physician, certain type of patient, meaning disease-wise, and it really helps sort of summarize any trends that you may be seeing. So again, this should be done on a quarterly basis, putting all of the quality tools, the quality root cause analysis tools together, and to help sort of really trend what's going on. And there's, sure, absolutely, Florence would like to add.
It's Florence. The summary sheet can also be used once you put your plan into place on how you're going to address the issues or the barriers that you're encountering, and you bring all your team members together to figure out how to do that. This now becomes part of your QAPI plan. You write it up and you put it in your little QAPI book, and when the state comes, you can just pull it out and say, this is the stuff we've been doing.
Excellent.
So use all the resources you have available to you.
Excellent, Florence. Thank you. Another tool that we haven't talked about is it's a tip sheet on how to engage your hospitals in the Interact program. It will help. This tip sheet helps you discuss the Interact program, why it's so important, and who you need to be connecting with at the hospital to make sure that they understand what the Interact program is all about and what to expect from you, and how they can help you sustain this program. It's a great tip sheet. It's about 3 pages long. It's not overwhelming, and it really just helps you focus on what the Interact program is all about. And finally, there is a nursing home to hospital transfer data checklist. This is not the transfer form that Sheila had talked about, but it's a transfer data checklist that you can use as you're putting together, if you're putting together an orientation program for a new nurse or a new grad that's coming into your building, to talk about each of the data elements that need to be transferred with that patient, where to find the data as they're filling out the transfer form, what data elements have to go with the patient, as well as what data elements can be faxed later once that patient is transferred due to an acute care transfer, and you can fax the data elements later once that patient is securely safe in the emergency department. It's a great tool, as I mentioned, especially for that new nurse coming into your facility or a new graduate nurse coming into your facility. Just a great tool, a basic tool to use. we stress this each and every session. Whenever you're out talking to the hospital or you're at a community meeting, you always want to tell your story about the work you're doing with the Interact Quality Improvement Program. You should have your story down by now, meaning that it should roll off your tongue when anyone asks you about, oh, are you in Interact Home? Yes, I am, and these are the tools and these are the processes we put in place. It's not about one tool, it's not about two tools, it's about the toolkit and the processes that you have implemented, and that's why Sheila went through what an Interact Home should look like. You should have your readmission numbers always, again, at the tip of your tongue, what your goal is, and also consider posters, visual aids, as you're telling your story to those new staff members or to whenever you have a staff meeting, have these posters or the visuals available so everyone knows this is the work we're doing and this is the culture now of our facility. Very, very important. So with that being said, we have some time to have questions. We have about 4 minutes left to have some questions. If you would like to ask a question, if you can hit *6 to ask a question about the Interact program or tools specifically. Florence, myself, and Sheila are in the room. So please, if you do have a question, and Tina and Laura are also online. So if you have a question to your nursing home colleagues, thank you for that recommendation. Please hit *6 for a question. Don't be shy.
The chat line is also open, so if you'd like to type your question into the chat box, we can take the question that way as well.
Thanks, Janine. I would love to hear from a nursing home in New Hampshire or Maine to let us know how you're doing, how the series has helped you, or what barriers you have encountered. Vermont, Massachusetts, or Rhode Island, you're also welcome to chime in. Okay.
I guess we did such a fantastic job today that no one had any questions. Either that or the weather is so crummy out, everybody just wants to snuggle up. So I guess we will wrap it up for this afternoon. I'll hand it to Karen.
Thanks, Florence. Again, if you have any questions about Interact specifically, the three of us are available, but also your leads, your community leads from the New England QIN-QIO, which I had mentioned earlier on, that second or third slide, please use them as experts also in the Interact program. Now, for the Connecticut nursing homes, I'm gonna ask you to stay on the line, but the New Hampshire nursing homes, Joyce is available to talk at 855-309-6568, and the passcode is 861-864. And for Vermont, Rhode Island, Massachusetts, and Maine, thank you so much for sharing your hour with us. We wish you luck, and again, we're just a phone call away if you have a question. So please, Connecticut nursing homes, stay on the line, and those New Hampshire nursing homes, you can jump off and join Joyce. And I'm sure Tim is with Joyce to talk about any New Hampshire issues. Okay, Connecticut folks, how's everybody doing?
I'm good.
Okay, now this is an interactive part of our session, so *6 to get yourself off mute. And as we have done for the past 8 months, we talk about our last month's homework. We discuss barriers and successes, and discuss next month's homework, which we won't have since this is our last session as a true webinar series. Now, I do want to talk about this Interact participation certificates. Yes, we have them, and yes, we're going to have them signed by our community leaders. The participant certificate basically says that you have participated with us for the past 8 months, that you have viewed at least 7 out of the 10 webinar sessions, and that you have sent Qualidime at least 3 months worth of readmission data. Now, you have several ways of sending us this data. You have it by giving us permission to view your data in Advancing Excellence. You have signed a data use agreement with us, and that allows us to go into Advancing Excellence and to look at your data. And all we're looking at is looking at whether you have at least 3 months worth of data in there. Now, also you had an opportunity to send us your data through the readmission tracking tool, and by using our grid that we have sent to everyone. Janine sent out an email 2 months ago with this grid, this readmission tracking grid, that, again, all you have to do is put in the first column, the second column, the first and second column, and then the very last column will be calculated for you. And then you would just send this off to us at least 3 months worth of data, just so we can say, yes, you are tracking your data. I'm going to go back to this other slide. So there's been several ways of getting this data to us. I do want to say up front that we only have about 19 or 20 nursing homes that have sent us the data. We have 91 nursing homes that are working with us throughout the 3 communities, which is New Haven, the Hartford, the Greater Hartford community, and then Middletown. So we need to get more data from you, from all the nursing homes, and we're going to let you have up till December 31st, 2015 to send us this data. We are also going to allow nursing homes up to December 31st to view the sessions that you have missed. Now, with that being said, we are not going to be working with nursing homes, we'll work with you, but we will not be giving out our certificate to those nursing homes that have just signed the agreement, the participation agreement, and then just started watching the webinars. That's not what this is all about. We are going to be giving certificates out only to those 91 nursing homes that have said from the very beginning, from the get-go, from December, January 2015, December 2014, and January and February 2015, that they are going to be working on this initiative. With that being said, we are going to be working with our community leaders and our internal leadership here at Qualidime, which is part of the New England QIN-QIO, to revisit providing this webinar series again in 2016. Oh, are there any questions? Florence is saying I'm talking way too fast, and I apologize. I get really excited.
All right.
Are there any questions about this?
Hi,
Star 6 to unmute your phone.
Oh,
I know. I'm sitting on my hands.
somebody just said something.
Please, if you have a question, chime up.
Hi, this is Karen from Villa Marie. How are you all doing today?
Good. How are you?
Good. You did mention that the certificates would be sent, but you didn't mention when.
The plan is, if you have met all this criteria, we are going to be meeting with the community leaders on November 19th, so we will have participation forms for them to sign at this point. And then we will be literally handing them out during the community meetings following that leadership meeting. So if you have a community leader meeting a community meeting at the end of November or in December or in January. We will be physically handing them out to the nursing homes during those meetings. If we don't see you, or if a participant of a nursing home that has fulfilled these obligations and a certificate has been created for you and we don't see you, we will then email it to you or mail it, hard mail it, snail mail. So because it's going to be, we're going to put it on a nice paper.
Thank you.
Okay.
Good question.
I have a question. This is Lisa from McLean.
Hi, Lisa.
My question really has to do with something that I know I've called the office on, and it's really a reflection on what the broader system is looking for from us. I know the Interact tool that we're tracking tracks our rehospitalization rates from within the facility. But the charts and the data that CMS is looking at is really looking at those patients that were with us, but left us and went to another entity and then landed back in the hospital. And that counts against us as well, if you will. And what I want to be able to figure out is how do I, and maybe there's best practices out there, that's what I'm looking for, how do I know who those people are? We are doing 30-day phone calls after they leave us, but I am not convinced that I'm capturing all of those folks accurately. Is there a better way to know who those folks are that end up back in the hospital after they leave us?
Hi, Lisa, it's Sheila. I know you and I have spoken about this. At this point, there really isn't, but kudos to you for that idea of calling people after 30 days to see how they're doing. I think that's going to be like the next big challenge for long-term care is how to, which is kind of where the hospitals are now, they discharge patients. How do they ensure that they have the right level of care for months after their discharge? And I guess that's going to be the next big challenge for long-term care is how do you make sure that handoff works well and whenever possible people are able to stay out of the hospital. But yeah, when you get into that area, you've lost a lot of control.
And Florence, Lisa, another thing that is happening now is having the discussions with your downstream stakeholders and your partners about bringing them back to your facility versus sending the patient back to the hospital. So if they have home care or if they're going home with their family member, just educating and just saying it over and over and maybe giving them a card or something that if within these 30 days they start to decompensate, please call us back because, actually you were the last person to have them versus the hospital and you would be able to provide the support that they need.
Correct. Yeah, that's a great idea.
Very different way of thinking here in the state of Connecticut. I don't think people very often think of sending someone directly back to a long-term care facility. So that'll be
that's actually heading the best practice now is to do just that.
Sure.
Yep, and we have been able to do that, which is great. I appreciate your feedback on that. Thank you.
Great question. That was a great question. Anyone else have a question?
This is Karen again from Villa Maria. I do have another question. You had indicated the different partners in the community. I'm in Eastern Connecticut. The closest partner that we have is Yale Hospital. Our admissions is less than 1% over the year from Yale Hospital. Is there any consideration or any thought in the future for other hospitals aside from Yale, like in Eastern Connecticut?
To be part of the preferred provider network, is that what you're asking? Or, well, that's going to be up to the hospital. And we're not part of the preferred provider. We are, the Interact intervention is really part of the CMS work we're doing as a quality improvement organization. So that's why there's no cost, there's no charge. But the hospitals are looking at this as best practice, and they are saying that they only want to probably work with nursing homes that have this part of their culture.
That's one of their requirements, is that facilities begin to use Interact. It's not the only thing that will get you in the door, but it definitely does help if you're doing that already.
I'm curious, Karen, where do most of your admissions come from?
Bacchus Hospital.
Oh, Bacchus.
Connecticut. We do have Hartford Hospital, Bacchus Hartford.
Right.
Hartford doesn't have meetings, community meetings.
Well, Hartford does. Bacchus has infrequent meetings.
Say again?
Bacchus has infrequent meetings, from what we understand. We've only been invited once or twice, but again, it's going to be this work is going to be spreading statewide. It really is. But that's an excellent question.
Right. I've reached out to Hartford a couple of times, and if you have a point person out there, I've exhausted my tool bag, and who do I reach to find out when the community meetings are and such.
Sure, you can, why don't you email me your questions directly, okay?
And I don't mean to be rude, but who are you?
How do you not know her? She said her name like 50 times already.
I know there's a bunch of you. There's only one of me.
You can either email me, Carol Dietz, or Florence Johnson, or Sheila, any one of us, and we can help you.
We'll help make that introduction for you, Laura.
Thank you.
I'm getting punchy. I don't know why anybody else.
So those are our contact information. It's at the very last slide of this the slide deck.
Okay, perfect.
So,
thank you.
You're welcome. You're welcome. Is there any other questions before I move on?
Yeah, this is Laura at Glastonbury Healthcare. I just wanted to, for anybody that's having any difficulty with the red envelope, we made our red envelopes. They're all ready to go. I have on the top of the red envelope the acute care transfer document checklist. And inside the packet, we have just a blank page that cues the nurse to print out a face sheet. And then we include in the packet the capabilities checklist, DNR status form, the SBAR nursing home to the hospital transfer form, that whole policy, and then another blank page that just says make sure you print out the updated med list. So when we have someone that we do need to send out, we just grab the red envelope. It's all ready to go. Just pull out the papers and fill them out, and then add anything else that we need to send. And then for the ambulance, we have another kind of a quick list where you just med list, face sheet, DNR, advance directive, and the SBAR being optional, and that goes in a brown envelope. So when they come in to transport our patient, we have both a red envelope and a brown envelope, and now as the team comes in, they recognize which one is theirs and which one is the emergency rooms. And that saves time. Everybody kind of gets hand-on, and we know exactly what we need to get. And in addition, we keep copies for our paper chart, and it goes under just an Interact tab right in the chart. So if there's any reference to what did we send out, we just go to that tab in the chart, and everything that we sent out is there for second review.
That's outstanding. Outstanding. Thank you so much. And again, it's all about pre-planning and making sure everyone's on board. And thank you.
Laura, it's Florence. I have a quick question for you. So as you started this process, what's your staff reaction to it? Are you hearing any feedback about it's taking too much time?
They love it. They actually love it because first of all, when we have to send somebody out, it's like all hands on board. So everybody kind of stops what they're doing. One person will make copies of the advance directive. Someone else is writing making sure the SBAR is complete. Someone else is doing the checklist. Someone else is making copies of labs. And we found by calling the triage that we have had, I would say, maybe one, if any, follow-up phone calls from the emergency room.
You no longer hear anybody saying, emergency room's not calling and saying, we didn't get this, we didn't get that. There's so much information that has gotten there prior to the patient arrival that there's literally no communication backwards. So it's worked out really, really well. And the staff know it's, when you do, after you've done a few, you just get into that time mode. I think it took more time to do a W-10, which basically you have to write everything, than to do this, the Interact, which is just really very time efficient. You know, it's, in the beginning there's a learning curve, but once you go, it's just like no big deal. It's just grab the red folder and here we go.
Excellent.
Awesome.
Excellent. Thank you.
I just have to say, I know we are way over, but this is great discussion, so we'll keep it going if people have more questions, but if not, if people want to jump off. But are there any more questions or recommendations?
It's Karen again. Sorry.
Hi.
Hi. Does anybody use the actual forms from Point Click Care?
For Glastonbury, we do not yet. As for Glastonbury, the S-bar is there, but we haven't been released to use it, so we're using paper right now. But the next step hopefully will integrate to the S-bar, because from my understanding is once you use S-bar, if the patient is not admitted and comes back to the facility, you can file the S-bar format in PCC as like a post-event note. But we haven't gotten to that state yet. And honestly, most people we sent out through the Interact, they're admitted. It's very rare it's an emergency room visit. Most everybody we've been sending out, except for I think 2, have been actually readmitted.
Now, Point Click Care also has a hospital transfer form that's Interact. Do you use that?
No.
Okay.
We do.
We use the face sheet, but not anything out of the actual internet. We just use the face sheet and the med list.
Okay. Because I found
but there are facilities around. Oh, I'm sorry. There are facilities around the state that are pulling from Point Click Care instead of actually using the hard copies off the computer.
That will make things even more efficient.
Yes.
I know certain.
We're using the PCC Interact transfer form at Kimberly Hall North.
Okay.
Oh, great.
Do you like it?
They really, that had made everything smoother once that became available rather than filling it out on paper. You know, they're very comfortable with PCC, so it's just a drop-down box and then it prints out, looks nice and neat, and they actually really bought in once that was available.
And that's part of the S-bar or Point Click Care. You have to purchase it an upgrade. We actually had to create an assessment that looked like an S-bar. Ask all the questions, but it's a part of the progress notes.
Yeah, it's the hospital transfer form for us. Okay. When it prints out, it looks like the hospital transfer form.
Okay, thank you.
All right. Just before everyone jumps off, we have just a few things to mention. We are going to continue with this kind of discussion for 2 months. We're going to have the Interact office hours for the Connecticut nursing homes, and it's our first one's going to be on November 18th, and we'll get this out into the email, a follow-up email to you all to remind you. But again, it's so important to learn from each other, the barriers and the lessons learned, and to share best practices. And then we're going to have one in January, on January 27th, 2016. Can you believe it? 2016, from 1 to 2. And I'm going to turn this over to Janine. She has a couple more things, but I want to say thank you so much for a wonderful, wonderful session today. Janine, take it away.
Thank you, Carol, and thank you, Sheila, and thank you, Florence. They're great. I hope that you really enjoyed their talk today, the series. I have a few final items before we end today's call. When you close out of the webinar, the evaluation should immediately pop up on your computer. If you could please fill it out, we would greatly appreciate it. If you don't have time to fill out the evaluation right now, or you're currently sharing a computer with someone else, you'll receive an email tomorrow morning with a link to the evaluation, as well as the link to the event page on our website. The PowerPoint presentation is already posted on the event webpage, but within the next few business days, a recording and transcript of this webinar will also be added. And finally, thank you for participating in this series. A reminder, as Carol said, that the Interact office hours will be on November 18th, so please plan to join us then. Have a great day.
Bye, everyone. Thank you.
you.